opportunity. I will be talking about the role of adjuvant chemotherapy in the early stage lung cancer. So as we know that almost 25 to 30% of the lung cancer present with the localized disease, and surgery remains the major treatment option in this particular subset of patient. But despite the surgical results, there might be the many patient who would be having a distant relapses or with or without any local relapses also. So we can see from this figure that how the 5-year survival decreases as we move on from the stage 1 to stage 3, and incidence of the distant as well as the local recurrence seems to be quite significant. So as we know that chemotherapy would be very much helpful in this particular subset of the patient where the relapses, distant relapses are majoritarily because of the micrometastatic disease. So from here, the concept of the adjuvant chemotherapy has come up. So the lung remains an area. So before 2000, there were many of the trials were carried out for the adjuvant chemotherapy. And this was a BMJ meta-analysis which was published in 1995. So they studied a role of alkylators, which was detrimental actually with 15% increased risk of the death. They also studied the role of the cisplatin-based chemotherapy, which has shown 13% reduction in the risk of the death with absolute benefit of 5% over 5 years, but it was not statistically significant. Based upon this meta-analysis, it has helped as a thrust for the development of the further chemotherapy trials in the management of the adjuvant lung cancer. So basically the reasons for failure of these earlier trials before 2000 were because of the small sample size, methodological flaws, and poor compliance of the to the chemotherapy because of the patient has undergone a significant surgical procedure like thoracotomy, and when we see post-operatively chemotherapy becomes really difficult to manage. And along with that, at that time the supportive measures were suboptimal, including the use of the antiemetic measures and the GCSF support. All these was contributed to the failure or maybe the non having very significant results from the earlier trial. So after 2000, but majority pace was evaluated, majority of the studies were undertaken based upon the BMJ meta-analysis, and many of the trials and meta-analysis has come up. So this was the most important trial called as International Adjuvant Lung Cancer Trial, which was published in NEJM 2004. And this was the first trial which was having a largest sample size of almost 1800 patients. And this was the first trial which showed that statistically significant survival advantage there would be with adjuvant chemotherapy. We can see the 5-year survival rate was improved by 4% and 14% reduction in the risk of the death. Along with that, PFS was also improved at 5 years. The chemotherapy related deaths were seen in almost 0.8% of the patient, and based upon this landmark trial, it led to the clinical implementation of adjuvant chemotherapy in the clinical practice. So from this trial, the patient who had a node positive disease, stage 2, stage 3, as well as the other patient who had a significant response to the chemotherapy, they did well as compared to the other. This was another trial, JBR-10 trial, which evaluated the role of the cisplatin and the vinorelbine on the against the observation in the patient who had been with stage 1B and the stage 2 except T3N0. So almost 500 patients were enrolled, and it was particularly carried out in Canada and the US. So from this trial, there was no survival benefit for the stage 1B patient, but stage 2 patient had a 80 months advantage versus 41 months for the observation with hazard ratio of 0.59. Again, this was a very important trial. That was the ANITA trial, which was considered as the Adjuvant Nivolumab International Trialist Association, and this was published in the Lancet 2006. So in this trial also, the median follow-up was 76 months, and it had shown an absolute benefit of 8.6% in 5-year overall survival, and with a hazard ratio of 0.8. So almost 20% reduction in the risk of death, while 5-year DFS was also significantly improved by 8.7% absolute benefit with a hazard ratio of 0.76. This trial has shown that there is a clear benefit of adjuvant chemotherapy in the stage 2 and stage 3 patient, while stage 1A definitely detrimental, while maybe selected subset of the stage 1 patient who are having a high risk factor, stage 1B with high risk factor might be beneficial. Apart from that, this was an important CalGB 9633 trial. Although the trial was not very, it was not a very positive result, but it was a only study which evaluated the role of the carboplatin against the cisplatin, and this has evaluated only in the patient who were having a stage 1B only. Small sample size was there definitely, and at the median follow-up of 74 months, differences in the survival were non-significant, and all these were attributed to the small sample size, carboplatin usage, and the stage 1B nature of the disease. But the exploratory analysis later on showed a benefit for the tumors who are larger than the 4 centimeter in the diameter with hazard ratio of 0.69. So later on, because of the heterogeneity of the various trials, the meta-analysis was planned, and this was a very landmark trial with the less meta-analysis, lung adjuvant cisplatin evaluation in the less collaborative group. So this was a pooled analysis from the 5 trials which use a cisplatin in the adjuvant setting, including the ANITA trial, big lung trial, international adjuvant lung, as well as the JBR10 trial. In this trial, basically, there was an absolute benefit of 5.4% at 5 years with the chemotherapy arm. And at 5 years, reduction in the lung cancer death was 6.9%. We can see the overall survival was significant with a hazard ratio of 0.89, while the DFS was also improved with a hazard ratio of 0.84. The salient features of this trial was, as we have seen, the heterogeneity with the individual trial. There was no heterogeneity of the chemotherapy effect in this meta-analysis, and the benefit varied with the stage, with the highest benefit seen in the stage 2 and the stage 3 patient. And the drug which was given with the cisplatin did not modify the effect of chemotherapy, which is very important in the clinical practice, because we nowadays normally doesn't utilize the vinorelbine in the adjuvant setting more often. While the effect of the chemotherapy was greater in the patient who had a good performance status, and there was no influence of other variables. So after a 2 decade of the research, ultimately it was concluded, and the results were termed as astonishing by the editorial comment in the JBR10 study. Then it was NEJM 2005, and we can see from the less vinorelbine cohort also, the 5-year, the absolute benefit was increased to 8.9% versus a 5.4% in the original less trial. So this was a best for the stage. We can see definitive improvement with the stage 2 and stage 3 patient. Stage 1 patient, 1A patient, definitely detrimental with hazard ratio 1.41. But there might be some high risk categories in the stage 1B, like a younger age, maybe the poorly differentiated histologies, visceral pleural metastasis, or the similar kind of feature which will be benefiting from the adjuvant chemotherapy in the stage 1B patient. So we can see from this study also, those patients from the stage 1B to stage 3, there was a benefit for 3%, 10% for stage 2, and significantly for stage 3, that is the 13%, which were alive due to the chemotherapy. And this was based upon the hazard ratio from the less meta-analysis as well as the ANITA trial. Similarly, these results were expanded from the various trials, and ultimately we can see for the stage 2 and stage 3, it would be definitely beneficial, but only for the selected high-risk patient of the stage 1B who can be benefited from the adjuvant chemotherapy. So this was a overall summary for this trial. Only one question that was raised, whether the benefit that were achieved with this chemotherapy, whether they were maintained over the long-term follow-up. So basically from the international adjuvant lung cancer trial, it was seen that the benefit what was seen, they were not retained after the 5 years basically. But the factor was that it was not an anti-tumor reduction efficacy, but more of the patient had died because of the non-tumor related deaths were there. But in the big lung trial as well as the JBR10 and the ANITA trial, the benefits were maintained at 9 years for stage 2 in JBR10, while ANITA trial, the benefits were maintained at 7 years for stage 2 and stage 3A patient, which confirm the efficacy of the adjuvant chemotherapy over the long-term follow-up. Coming toward the toxicity profile, as we have seen, majority grade 3-4 toxicity were the neutropenia across these trials, and the nausea and the vomiting CINV was a major aspect. But I think with the current supportive care, with the improvement in the antiemetic and the GCSF prophylaxis, these incidents can be really brought down. So when we talk about the treatment related deaths, there was a 0.8% with the ILT and the JBR10, but there was slightly higher number of the death, 2% death in the ANITA trial. This was attributed to the higher doses of the chemotherapy which were used in the ANITA trial, and this investigators also they advise for the lower doses of the chemotherapy in the patient in the clinical practice, just to bring down the incidence of the adverse event. And when we see the median number of the cycles, at least 3 to 4 cycles were given all across the trial. So now we consider 4 cycles as a standard of the care for adjuvant chemotherapy. So when we talk about the long-term adverse event, there were many of the concerns were raised, but with the exception of the sensory neuropathy and the hearing loss, it was seen that majority of the side effects were recovered and the quality of the life was returned to the baseline by 9 months after the completion of the treatment. And even there was no adverse impact on the pulmonary function, which was thought as a potential adverse event. Coming toward the quality of the life, it was assessed in the subset of 357 patients from the JBR10. Chemotherapy patient had a transient worsening of the quality of life with development of fatigue, nausea, and the vomiting, but they resumed to the baseline by 9 months, except was seen already with the hearing loss and the sensory neuropathy. And the assessment of all the patients showed that adjuvant chemotherapy improved quality adjusted survival despite the toxicity of the chemotherapy. So now we see more often pemetrexed in the non-squamous lung carcinoma. So this was taken from the phase 2 feasibility studies. Initially, it was a phase 2 PEMSIS and versus PEMCARBO. Feasibility 4 cycles, more than 95% of the planned dose with no grade 3-4 toxicities in more than 60%, which was seen in 59 and the 50% respectively. While overall survival for both these groups was almost 82 to 83% at 3 year and similar at 5 year also. There were another single arm studies which has shown the importance of the pemetrexed in the adjuvant setting. Apart from that, this was a GPANG study which evaluated the stage 2 and stage 3 year resected, completely resected non-squamous histologies with good PS and age between 20 to 75. They were subjected to the cisplatin pemetrexed versus cisplatin and vinorelbine, and they concluded that pemetrexed with cisplatin had a similar efficacy as compared to the vinorelbine and the cisplatin, with a better tolerability as a post-operative adjuvant chemotherapy for non-squamous patient, and a significant interaction although was found for the relapse-free survival between the treatment and the EGFR mutation status. And in patients who don't have the EGFR mutation, PEMSIS appears to be a preferable regimen as an adjuvant chemotherapy. So these are the NCCN guidelines these are the standard chemotherapy regimen that has been also advocated by NCCN. And ultimately, although the majority progress has been made, still there are many of the areas that need to be covered in the adjuvant setting, that is mainly taken care with the targeted therapies and the immunotherapy. Maybe in the future, we might see the more improvement in the survival status. Thank you.